gonna wait for a couple. Good day, everyone. We are just gonna wait for a couple of minutes more for people to join, and we're gonna start our Rolandic resection session very soon. Thank you.
Thanks.
Good day, everyone. Welcome to our webinar on Rolandic resections. We have today two wonderful speakers, Marcelo Volpon and Delev. After their presentations, we are gonna be enough time for discussion. Please send your questions or notes to the chat so that we could look into that and discuss this after the presentations. May I remind also you on our epilepsy surgery technique meetings that's going to happen in Dubai, January 19th to 21st. All invited. It's an excellent opportunity to meet all the group and to be able to see the challenges and the new things on technical issues of epilepsy surgery. Without further delay, I would like to invite Daniel Delev from Aachen, Germany, to share his screen and present his paper. Daniel, please go ahead.
So, well, thank you very much, Arta. Thank you very much for the invitation. Just give me a second to share the right one. Should be this one. So now we should be able actually to see my screen as well. Yeah,
that's correct.
So it's very nice to be here with you guys, and I hope that in the next 10 to 15 minutes, I will be able to present an interesting case. We can discuss further on it. And again, also for everyone, please free to put any questions in the chat. We may answer them within the presentation or after that. So it's about Rolandic epilepsy case-based scenarios. And I think it's good just to start with a very, very short definition of the Rolandic cortex. It's this very good image from the landmark paper of Ricardo de Oliveira, where he reported about Rolandic recessions in pediatric cases. So it's most of the time Rolandic we would see this as a gyrus, the precentral gyrus, the postcentral gyrus. But as we talk about epilepsy surgery, some of the lesions might include also the frontal or the parietal lobe. So he also put this additional frontal Rolandic and parietal Rolandic. And most of the time we would look for a seizure causing lesion. This can be at the hand motor or face motor, because this has some, I think, influence about the decision-making process. But because this is a case-based scenario, I would like to present a case. It was a young man, male patient, 32 years old. Seizure onset was 2015. The clinical presentation was more or less than the semiology speech arrest for several seconds. It was very difficult to find out the frequency of the seizures. It could be like a series of many seizures or many speech arrests in a few seconds every day. But then he had like for 3, 4, 5 months didn't get any seizures at all. He was put on medication. It was levetiracetam, 1 gram, 0.1 gram, and he showed no further neurological deficit. So, of course, we did make MRI scan, and these are the MRI scans showing also the follow-up from 2017 until 2021. So you would see this lesion, which is actually in the bottom of the precentral and postcentral gyrus, looks very much like a low-grade glioma. And on a long term, you might probably notice that it gets a little bit bigger. But if you compare 2019 to 2021, you would most probably see it's just a bit different type of MRI flare images, but it stays more or less stable. So it's a very slow growth of this lesion. So looking on the sagittal images, then you realize that also there is not much of a or the dynamic is a little bit slow. This is also like, 4 to 5 years in between. This would be the central sulcus in between here, and of course the Broca area, which would explain the speech arrest and the semiological presentation. And yeah, it gets to some extent to the left insula, but if you compare it on the FLAIR images, it's just most probably the upper part of it, because it at least from the signal it looks the same. We put this young male on a video EEG monitoring for 4 days, and unfortunately, despite withdrawing the seizure medications, we didn't get any seizures. We got, however, some epilepsy typical spikes and some swall waves. You see it's a T3, T5, so it's more temporal. Having in mind the lesion, one could actually quite well explain why we would see this in the temporal lobe, but we couldn't really record, at least in those 4 days, a real, or at least a clinical presented seizure. So we did also a neuropsychological examination. To cut it short, it was more or less without any problems. So he has a bit of a, like some, well, on average, it was normal. So the complex and the simple and complex attentional abilities and visual and verbal memory spans were a little bit longer, but he did quite well. So we went a little bit further on, wanted to characterize the lesion a little bit more. So we performed F-Doppler PET examination, which was the idea to show us whether this tumor has a hotspot in there, and just to realize and know a little bit more about the metabolism of the tumor. It actually showed a place which was just above the average for a hotspot. So the F-Doppler PET examination would tell us that this is a kind of an active tumor at this point. So we were a little bit afraid that it might be a little bit more malignant than just it seems to be on the MRI scans, because it didn't grow over 5-6 years in that extent. And then we discussed this case in our board, and we were thinking about some anatomical and surgical consideration, and I think this is important. So if you have it like this was the central sulcus, so it will be the precentral, postcentral. We have the Broca area there, and it was the question: can we resect it, and how can we resect it? At least in our experiences, that you could resect above 3 centimeters above the Sylvian fissure, of course, still being below the hand knob, the hand area, and this could be quite well tolerated from the patients. So this was the first strategy. We did also some DTI tractography, tracking the fasciculus arcuatus and the corticospinal tract, and I apologize for the image. I just couldn't get it a little bit, couldn't flip it. But you would see that the fasciculus arcuatus would lie at the behind of the tumor and actually go through the white matter parts of the tumor. So the tracts were involved in the tumor, in the posterior parts of the tumor, and this is what was the anatomical and clinical situation there. So we were a bit of discussing the case. We did have some epileptological considerations, seizures despite anti-epileptic drugs, but we do know that if we resect on this only because of the epilepsy, we would be able, or we need to try to achieve a complete resection, which might be, at least in this case, maybe not possible. So maybe a question after that for everyone for the discussion: what would you do? Would a cortical resection be sufficient if you want to address only the epilepsy? So not going to the white matter tracts, where it becomes a little bit more dangerous. And of course, we have the oncological considerations on the other side. So it was a slight tumor growth, but it was growing. However, it's an eloquent vocalization again. How large can be the extent of resection? And of course, if we presume that it was an oligodendroglioma because it was growing slowly, we know that there, if you could do a biopsy and have radiation and chemotherapy, something what the patients would actually get, and this is a good treatment, at least for of course, additionally to the surgery. But of course, you don't address like doing this. You're not addressing the epilepsy issue. So it was like we were discussing: do we do surgery or do we do biopsy? We get a hotspot, so we could actually do a biopsy from this hotspot. And if we decide for the surgery, what would we do? Do we do it awake or do we do it asleep? So of course, awake would give us the possibility to map the language in a very nice way, especially in the white matter area. In a subcortical way, but of course it's on the other side, it's an epilepsy patient, so we have an increased risk maybe for becoming an intraoperative seizure. This would be also would really like to know what's your opinion about that. And of course, doing it asleep, it would be a little bit more difficult, or so we will have to do only on the anatomical criteria. So what we actually did, we go for a resection because we said, well, we want to address both aspects. We want to address the epilepsy aspect, and of course we want to address the oncological aspect and do it awake and trying to take as much as possible of the tumor. So we resected the bottom or the lower parts of the precentral and postcentral gyruses, and we map intraoperatively. At some point he did get actually a speech arrest, and this is where we stopped the resection. So at this MRI scans, it looked quite nice, but if you go a little bit upper, then there is certain area where we left some tumor in there, and we did also a DTI tractography afterwards to see where the corticospinal tract and fasciculus arcuatus were. So it was actually going exactly through this area here. So I think it was maybe the best option for the patient to stop at this point and not going further. Luckily, we didn't get any seizures during the awake surgery, but we did loaded him with Keppra levetiracetam just before the surgery, and he took another doses during the surgery. This is not really evidence-based, I think, but we felt a little bit more secure about this, and we worked on him after that. So now it's more than 1.5 years. So he has no seizures after surgery. He got a facial palsy for 8 weeks. So it was quite heavy for him at the beginning, but it resolved completely. And this is something we do feel that it's at least our experience for this part of the at least for resection in this part of the precentral gyrus. He still had some numbness of the face and the right hand, which I cannot explain. The medication, he's still on medications, no further neurological deficit, and the histology was actually oligodendroglioma WHO grade 3. So he went after that on radiation and chemotherapy, and he has now for 1 year stable disease with no progression and no further deficits. So just as a last few slides or last slide, just to like to put some input in the discussion about the resections in the Rolandic cortex, we did actually look back in 2 different hospitals, in 2 different cohort of patients. The one was in Bonn and the other one was in Freiburg. So if you do resections there, you get a high, if it's a pure Rolandic, like the precentral, postcentral, you get a high rate of permanent neurological deficits, but you can also achieve a very good seizure outcome. And of course, it gets a little bit worse if the lesion is so vast that it involves both pre and postcentral gyruses. And on the other hand, when we discussed this case, we always had this problem going for surgery, at least at the beginning, because we knew that the best predictive factors for extratemporal epilepsy to become a seizure-free is if it's not non-eloquent and if you can achieve complete resection on MRI, which was from the beginning why we knew that this might not be possible. And with this case, I would like to end the presentation, and I hope of very vivid discussion and many questions. Thank you.
Thank you so much for this, Daniel. And indeed, I anticipate a lot of discussion. Before starting discussion, I would like to invite our next speaker, Marcelo Volpon from Ribeirão Preto, Brazil, to present his case or his discussion. Marcelo, please go ahead.
Okay, thank you. Let me just share my screen here. Okay. Good day, everybody. Morning, afternoon, evening. It's a great pleasure to be here. I feel very privileged to be among very important figures in epilepsy surgery, and it's certainly a very nice learning opportunity for me as well. I still think I'm a newcomer, so thank you a lot for the invitation. I don't have any conflicts of interest, no disclosures, apart from the fact that I'm a pediatric neurosurgeon. So differently from Daniel, I'm going to present pediatric cases. And I took the liberty to actually prepare 2 cases. I promise I won't be too long. It's just that I felt that they would complement each other, and I think it might make the discussion even better. So the first one is the case of a 15-year-old boy. He's right-handed, and he had a history of focal motor seizures that involved the right upper limb since he was 8 years old. So he had a history of febrile seizures in early childhood that were controlled with clobazam. And, you know, his seizure frequency actually changed, but he was still seizing quite a lot. When he came to us about 5 years ago, he was seizing like 10 times a day. And he was already at that time pharmacoresistant. He had been on phenytoin, oxcarbazepine, and clobazam, and was now on Keppra, phenobarbital, operated, but still seizing that much.
Marcelo, sorry to interrupt. Could you speak a little bit closer to the microphone, because your voice is waning?
Okay, yeah.
Oh,
and I can speak a little bit louder. Is it better?
Much better. Thank you so much.
Thanks. So he didn't have any alterations on his physical examination apart from a mild cognitive delay. Speech was a little bit delayed. No previous pathological history. And as you see in the video EG, his seizures had now progressed to bilateral tonic postures with very, very rare secondary generalization, and they were very brief in duration. So this is the video we got from his EEG. Sorry. So he had first this head tilt or head fall to the left, and then this sort of asymmetrical tonic posture of the upper limbs, then a little bit of eye deviation to the left as well. And it's quite briefly, as you see, he recovers fully within just a few seconds. And that's it. And then his back would be, you know, S-ring normally. I don't have the actual EEG, but I do have the report, you know, prior to the admission, which said that he had central parietal spikes on the left side, but he also had this bilateral frontal central spikes, spike and wave discharges, which were quite sporadic, but which made him to be treated as having juvenile myoclonic epilepsy. When he got to us, he was being treated with this diagnosis, and actually didn't work very well. So he had been seen in many centers before he got to us. So he had 4 or 5 MRI scans before this one. So all these scans, this is the first one he had when he got to us. It's actually, I know, after a lengthy discussion with our radiology team, it was thought to be normal. I can go back to it, you know, if anybody wants to. But indeed, it's quite difficult to interpret, but there are no gross alterations, even on T1, T2, or even with flare scans, you'll see here. Now in hindsight, and I'm going to sum this up in the next slide, you can, appreciate a slight signal alteration in the left Rolandic area. But just to sum up with some pictures now, after a lot of other scans, and this is the last one prior to what I'm going to show you afterwards, we thought that there was some signal alteration in this area, which is just not exactly in the motor strip, just a little bit anterior to it. You appreciate that the cross-central lobe is around here. So this lesion is just anterior to the Rolandic area. Nuclear medicine studies were also quite interesting. His PET-CT was deemed normal, but his ictal SPECT not only showed bifrontal hyperperfusion, but indeed showed this left Rolandic hyperperfusion. So it indeed looked like that there was something going on in this particular area. So after all these investigations, we had, our options were threefold. So we could either go straight to the operation and perform an electrocardiography and intraoperative functional mapping, or we could go for invasive monitoring, either subdural grids or ICEG. We did feel that this, although that area was really suspicious, but we still weren't that convinced, and now it's always easier to look inside. But we did feel that this case needed further monitoring. So we went for an SEEG. This is the pre-implantation planning. Basically, all the strategy was to, monitor the whole area surrounding the lesion. So this is where the electrode that we call that inside the lesion was supposed to be, and everything else around it. This is post-implantation. You can see the lesion is here, and all the ICG electrodes are just surrounding the lesion. This electrode in particular was the one who was supposed and was actually touching the lesion, the deep response. So this is the non-filter scan, but I think that after we filter it, it becomes even more clear that you had this continuous spiking in the electrodes that were inside the lesion and just posterior to it, and motor gyres. So this is pretty much what we saw even before the implantation. And this is when we consider that he would start seizing, and we saw this very fast activity, particularly here and here. So I think now it became clear that the epileptogenic area was indeed centered in the lesion. So then we went for the operation, which was pretty much a lesionectomy, a not so expanded one, but we did have to remove because the lesion was in the hemispheric region. So we wanted to remove it a little bit more, and we did go upwards into the hemispheric region. So this is the post removal. This is post resection. Not only removed the upper part, but we also went down and used the electrodes to guide us so that we could remove this plastic area completely. Pathology came out to be a cortical dysplasia type 2A. The patient did well, very well afterwards, as you can see here. He does have something here in his right lower limb, but he actually recovered quite well later on. No upper limb deficits. This is 2 or 3 days after the operation. As I said, it was not that large of a resection, but indeed it encompassed a little bit upwards and then the full region here. So after 5 years, we just saw him last a couple of months ago in our clinic. He's been seizure-free just after the operation. He's gone to law school, performs fairly normally. He's got no motor deficits, but he's still on capra and topiramate. He wasn't managed to take off all his medication. So just to complement, another case of a 10-year-old girl, who's right-handed. This one is quite straightforward. She only had one type of seizure, which involved twitching or trembling over the right side of her face, you see in the video, which had started just a year before. She didn't have any personal or family history of seizures. Apart from the facts, I'm not sure how important this is, but neurologists felt so. But mother was a heavy smoker, and she didn't find her pregnancy until later on. So she smoked pretty much during half of her pregnancy. We cannot say that she's not controlled. I mean, she's not fully controlled. She's still seizing weekly, but she spent at that time months without having seizures, and she was only on carbamazepine, regular dose. So she didn't have any physical, general neurological alterations in the examination. And also her neuropsychological testing wasn't that altered. She was just a little bit below average for age for reading and writing. The reports was something about attentional deficits, but she performed quite well. She went to a regular school, so she didn't have any major problems in that field. This is her seizure. Very interesting because it comes, she's playing with her cell phone, and then she starts twitching, just around her mouth. And then she realizes very quickly that she's seizing and calls for her mom. Her EEG is quite difficult to interpret, I'd say, because she's got all these muscular artifacts. But it looks like there's something going on. This is when the seizure starts, and reflects there's something going on, just in the frontal central electrodes. This is when she realizes and calls her mom. So as you can see, it's a very brief seizure. And this is her scan, which was actually referred to us in August last year. So there's a very clear lesion, just the inferior part of the Rolandic area, more anteriorly, but still certainly encompassing the face area. Pretty much a cystic lesion. It had a cystic component and a nodule, and a little bit of surrounding edema, T1 and T2. This is the flare picture, so you can appreciate the edema and also the sagittal cuts. Vision is quite clear. So interestingly, we actually she was admitted for a video EEG in that period, and it took some time so she could go for the operation. Finally, I was actually a little bit anxious, a little bit afraid of the operation, so they actually delayed it a little bit. But just before we had the opportunity to take her to the OR, we decided to perform an MRI scan because it's been roughly 3 months after the first scan, and you can see this huge growth just within 3 months. See not only the cystic component but also the solid part, which we grew quite a lot. Same thing for all the other cuts. Very appreciable growth of the lesion. As you can see here, similar to Daniel's case, the corticospinal tract, the tractography was dislocated posteriorly and medially, which took us to have a more anterior strategy. So we went into the lesion from the central lobe. Also the arcuate fasciculus was dislocated posteriorly, so we weren't that concerned with it. I'm sorry, I've been struggling with the video. I had the intraoperative video, but somehow it got corrupted and I couldn't fix it. But basically, it was a very straightforward tumor craniotomy. I just wanted to make sure that where the hand motor area was, so we could see it. So that's why I used intraoperative simulation. Well, with the aid of neuronavigation, we found a socket that went straight into the lesion. The lesion had a cystic component. So once we got into it, we could detach the capsular membranes quite easily, and even the cystic part. So that after the operation, I think we got a fairly good result. This is just the day after, so there are still some post-operative changes, but we were convinced that resection, the deletion was fully resected. From an epilepsy standpoint, the child is doing quite well. She's been seizure-free. She was operated on last December, so she's been seizure-free for 9 months. Sorry. So what's interesting here that pathology came out to be a little bit different. It was a pleomorphic xanthioastrocytoma, which is grade 3. So she was put on radiotherapy. She was already received her radiotherapy dose. And she was put on temozolomide. She's just received these cycles that she's now on maintenance therapy. So just a couple of points for discussion. As Daniel mentioned, I just wanted to clarify a little bit about nomenclature, because when I say Rolandic epilepsy, of course, we're referring to the central lobe, which we're all very familiar with. We always try to find the central sulcus in most of our operations. We know all the craniomedic relationships, the representations, and we also know of the functional connectivity of the Rolandic area, which is quite big, as you can see here, even in patients seizure or not, as compared to controls. So this is why, and that's why I was a part of this article that we published some years ago. This is why I've decided to further classify the Rolandic epilepsy into this lesional Rolandic epilepsy, into these 4 categories, because it's quite rare, as you see, this is our own case series, that you have a pure Rolandic lesion. I mean, we did have some in the upper motor area, or inferior motor area, but it's more common that the lesion not only sits within the Rolandic area, but also encompasses frontal and parietal areas. So pretty much the epileptogenic network is much more widespread. And also, just a matter of nomenclature, when we talk about Rolandic epilepsy, most of these epilepsies are not that interesting to us neurosurgeons, because they were what used to be called the benign epilepsy with temporal spikes. That's when you mention Rolandic epilepsy to a neurophysiologist, they're gonna think about this entity here, which is what used to be called Rolandic epilepsy or benign epilepsy with temporal spikes. But what's interesting, what matters to us, is that Rolandic epilepsy with structural band lesions, of course. But we do have some Rolandic epilepsy, which is indeed quite benign, so to speak, which resolves and with time, even if it has a genetic background or if it's related to other epilepsy syndromes, but it does resolve until adolescence. So the one that matters to us is this 4th term. Of course, we all appreciate the differences between children and adults. And we know it takes some time for epilepsy to become intractable. So particularly in the second case, I think there is, it's important that we highlight that, and this has been our rationale, pediatric epilepsy surgical service, that surgery should be indicated early. I think that fortunately, 3 months wasn't that much of a time. It wasn't that delayed. But I mean, if you wait for years, maybe, because of the effects on brain development, and because some of these cases might even develop an epileptic encephalopathy, there's no question that surgery should be indicated. Also, what's particular, and then it's interesting that Daniel was presenting a case of this, is that we are all very familiar with LEADs, which do have a very slow growth rate, but some cases might be a little more aggressive, and we even have, malignant tumors presenting with seizures, and of course they're much more frequent. So we will face these tumors at some point. So it's important to keep them. Last, as Daniel said, and I'm going to be very brief about this, we did study our cases, first 48 cases that just want to show you our results. So very summarized, we were able to perform complete resections in roughly 80% of these patients, and about 20% had incomplete resection. This is the distribution according to location. The outcome is quite good, even in the short and longer term. 74% of angle 1 and 2 in the first year, and in 3 years, even though we lost the patients to follow up. Still, we had 80% of patients classified as angle 1 and 2, which I think is quite good. And our biggest fear, of course, which is the persistence of permanent motor deficits, certainly is not entirely justified. As you can see here, only 18% had permanent motor deficits. None of them was actually hemiplegic, so some of them had deficits that were functional. 40% did worsen, but half of them actually recovered, and almost 60% had their motor status changed. So I think it's not entirely justified that we fear. I think we can go the extra mile. That's what I'm trying to say. Even if the patients do have some deficits, I think they recovered quite well. And this has been proven not only by us, but Daniel has shown the results. And also the literature has a nice rate of seizure outcome and permanent deficits. Indeed, it has a trend that they are getting better. I think that with technological agents and development of other more sophisticated techniques, I think that we'll get even better results with lower complication rates. So that's it. Thanks for the attention. I think we do have a good overall outcome in epilepsy, Rolandic epilepsy. The motor complications are acceptable and recoverable. And thank you for the attention. I just want to thank the team I'm privileged to work with in Southeastern Brazil. And hopefully we'll have a nice discussion afterwards. Thank you all.
Thank you so much, Marcelo, for this beautiful presentation. Maybe if you please unshare so we could have bigger pictures of everybody. Yes. Okay, perfect. So thank you both, Daniel and Marcelo, for their presentations. I brought Jeffrey to the panel. Jeffrey, you have some comments, right?
Well, first of all, I thought both the presentations were really excellent. Very, very interesting points, I think, raised by each, particularly the first case with it being a lesional epilepsy, the second case with the attention to whether or not the motor deficits imparted by Rolandic and peri-Rolandic resections are permanent. Those are super important issues. And I, like the second presenter, do pediatric work, so I think that is slightly different. The question that I posed just actually came from a review that we just recently were talking about in our group, and that was that some of the molecular therapies are beginning to make some real inroads for some of these lesional cases, right? That low-grade gliomas with specific mutants are showing greater response to some of the chemotherapies. And what I had never seen, I was just posing to the group, is most of the outcomes of these studies, which are admittedly early, are radiographic, that talk about a reduction in size or things like that. And I haven't seen very much work on whether or not the radiographic shrinkage correlates with reduced epileptogenicity. And I was just wondering if anyone in the group had any either experience or had seen any data on that, because that, particularly for these Rolandic lesions, like the first one where you've just got a diffuse problem in the motor cortex or immediately adjacent to it, additional therapies beyond gross surgical resection would be useful. So thanks for the opportunity to pose the question, and my compliments to both presenters. It's great to be back as a group.
Nice to see you, Jeffrey. Daniel,
Yeah,
Marcelo. Yeah. Okay, go ahead.
This is very important. Thanks for a question. Very important one. I have to be honest, I have never seen data on the epileptogenicity. One could, I mean, we can hypothesize that, yeah, of course, it's if you do something with the IDH mutation now, it's, you know, like isostrate dehydrogenase, and there was also a quite good paper about why IDH mutant glioma would generate seizures going through alpha ketoglutarate. So I think that it should be some kind of effect, but I have never seen data upon this, because I presume that everybody concentrated first on the oncological part. What I presume, but I cannot prove it. It would be interesting to give the medicament wait a little bit more longer. What the New England Journal of Medicine paper showed is that actually you don't really heal the glioma, but you kind of turn it to a more not an acute disease, but a chronic disease, you know. So it's still there. So it shrinks, but it becomes more like a chronic disease, which is of course a great development, but it's not gone. So I think that having a glioma as a chronic disease would definitely have put it the other way around. I think that we'll have a big problems with the seizures in the future. so maybe because now we have a disease which is chronic, which is in there, which makes something, and even if the exactly the oncological part is under control, I think that we might have some issues with the seizures, but I've never seen data upon this. And I think this is because just the paper is like a few months ago, it came out. You know, everybody's talking about this right now. And I think it would be, I suppose that the authors will publish sooner a second post hoc study about all these interesting questions, because we'll presume that at least 60 to 70% of those patients will have had seizures, you know.
Marcelo, any comments?
Oh, yeah, I agree with Daniel. I'm happy to hear any comments from more experienced panelists.
Could you speak near to the microphone, Marcelo?
Yeah.
Again? Yeah.
I agree with Daniel completely. I mean, I don't know what's, you know, that resection is certainly one of the most studied prognostic factors. But I'm not sure if, you know, if a drug is gonna restore the connectivity and the epileptogenicity of a given area with a tumor. I'm happy to hear any opinions of the experienced panelists. I don't know, I think I agree with Daniel. I think we're going to be seeing still patients with epilepsy, even with these new targeted therapies. I don't have that much experience from an epilepsy standpoint, but we've been using tumor patients. And I don't know, I just can't say for epilepsy. I know that they've been, you know, they recover from deficits. I think they get a lot of benefits from it. But I'm not sure that these drugs are gonna restore or reestablish the normal electric circuitry. So we'll see. It might take some time for us to know.
Guy?
Yeah, I think that my I guess combined prediction plus based on what's out there, there's a pretty good review article in JCI from this year that kind of goes over all of the experimental data on this topic. And, you know, there's pretty good animal model data, both in terms of IDH1 mutant gliomas put into different animals, as well as with steroids and things, that IDH1 blockers are actually very beneficial. And there's case reports that people have published of patients doing a lot better. So I think the issue becomes on a case like Daniel's is that obviously at some point that tumor is going to progress. There's insular involvement. And at that point, you know, are you going to go back and reoperate? Or at that point, is an IDH1 mutate, or, you know, IDH1 inhibitor potentially going to provide more medical treatment? I look at it as it's not going to be an either or. It's going to be mutate, you know, IDH1 blockers and then surgery, or surgery and then IDH1 blockers. And it's just going to be another thing that we're all using together.
Christian, please.
Well, I could add to the discussion that what we do know, what we seem to know, is that radiotherapy has an effect, a positive effect on the seizure outcome after radiotherapy. So, and in most of these tumor cases, patients are now receiving not only chemotherapy, but radiotherapy in combination. So I think it's going to be hard to divide and then see what the effects of these therapies are when it's very often done in combination. So, but for radiotherapy, there seems to be a positive effect on epilepsy.
Thank you. We have a couple of questions from Khalid Al-Orabi. It's probably related to Daniel's case. Is it better to proceed for surgery on the 2017 when the lesion was smaller? And in eloquent areas, do you prefer to perform surgery once diagnosed? And if so, awake or with any other type of mapping?
Yeah, I think we didn't I think to the first question, definitely yes. I think one, if it is a symptomatic lesion there, and it was a smaller one should have characterized it at least 2017, and having in mind that it's a oligodendroglioma, I think the one could have operated on this on an earlier stage. It's better for the epilepsy, it's better for the tumor. I don't know why one should wait for this long. The patient was referred to us after he has been diagnosed in a few other centers, and it was said that it's difficult to operate on, so one would wait. But the answer to the question, at least my personal answer, would be yes. If you have a symptomatic lesion, both your epileptic and oncological aspects benefit actually from the early resection. About the second one, yeah, we would do most of the eloquent areas would do in awake condition nowadays. So, but maybe it's just from center to center. I'm not someone that would say you have to do everything awake. We kind of at least for our center decided to have, if it's in an eloquent area, we would feel more comfortable to do it awake. You can do a very fast mapping. You don't have to keep the patient awake all the time. If you have a good navigation and the tractography planning, most of the time it's always about a few millimeters, centimeters where you're unsure, and you can go straight forward there, and then you know whether you can resect it or not. And normally, I don't know what was that. I can also actually look at the chat, because there was a third question. Smaller, yeah, general question. Do you prefer to perform surgery once diagnosed? You mean like doing a biopsy before doing directly surgery? I suppose this is the question. I think if this is the question, I think both ways are okay. But nowadays the MRI imaging diagnostics, and if you have also a PET scan and all this stuff, you don't know what kind of a molecular tumor it will become, but at the end of the day, it stays a tumor causing epilepsy. And it was also the case in Marcelo, this pleomorphic centroasterocytoma. No one would have expected to explode within 3 months, actually. So I think that if you feel more, you can do a biopsy prior to surgery only if this influences your further actions. Now, when we have this targeted therapy, and we know that it's a oligodendroglioma, for instance, as Guy said, we might first do any kind of medication, radiation, and then perform surgery. But I also think that it will be not either or, but it will be more both and, question. Yeah.
Thank you, Daniel. Christian, please.
Yeah, I have a question for Daniel, or for the others as well. So Daniel, when you're saying eloquent and awake surgery, you're talking about language, or do you use the awake condition for motor only as well? And then a technical question, are you using subdural strips during your awake procedure to monitor for early seizures or after discharge potentials?
Yeah, so we've started. So to the first question, speech, anything which is involved, we do awake, and because we feel so comfortable and our anesthesiologists are quite keen on this, so we now started doing it also for the motor cases, but with this not. I mean, we are also very used to do it the motor, or we started doing, of course, motor under electrophysiology, and we feel very comfortable with the results we get there. So it's more like just for a better mapping, we will do also on a motor, but it's definitely most of the cases are about language mapping. And yes, we use an electrocardiography during the surgery to kind of predict a seizure. So we do always electrocardiography together with the epileptologist. One reason is, of course, about looking for seizures, and not only seizures but epilepsy typical potentials. But then we keep the strip inside as just to be sure, or at least to see some activity if a seizure is coming. we do that.
Do you
Yeah.
do you use any intra-op stimulation? And
Yeah.
if so, monopolar or bipolar?
We use monopolar subcortical. Yeah.
Okay, Marcelo, would you like to comment on how you do that there in Ribeirão?
Yeah, we don't have a, that's one of the main differences of children and adult epilepsy surgery. We don't have almost any experience with awake surgeries because it's actually, even for practical reasons, quite difficult in children. So, and the second thing is that we're not that afraid of deficits, particularly in younger children. We know that they recover. We just studied on left hysterectomy patients, and they do recover quite well. There is plasticity and transference. So that's one of the reasons why I actually have no experience with awake surgery. But we do use all, apart from that, we want to keep the patient well. So we do use tractography and everything else. We use intraoperative stimulation as well. So we can use everything, but I think in children we can be confident to go, the extra mile. Without that, we will fear, but not that much, that the patient will have deficits just afterwards, because most of them will be recoverable.
Do you use any intra-op stimulation in your sleep patients?
Yeah. Yeah.
Monopolar, monopolar, bipolar?
We use bipolar. It works.
Mm-hmm.
I mean, the problem in children is that young children, as you all know, it's quite frequent that we can't find the motor strip perfectly. But in children over 4 or 5 years, it's quite easy to identify. But we do use that whenever, for the second case, for instance, which we would just go anteriorly, and that the motor strip would be certainly spared. We used stimulation, and we try to find the motor whenever we feel that there's the need to localize it, with more precision.
Thank you. Guy, please.
Yeah, I had two separate questions, both for the panel and also specifically for Daniel. So Daniel, you were talking about the 3 centimeters above the sylvian fissure in the Rolandic area often being resectable. And what do you think is the difference between that dominant versus non-dominant hemisphere? Where do you worry in the dominant hemisphere about potentially resecting dominant face motor, or do you not worry about that? And a separate question, a case like yours with an infiltrating glioma, when do you think it might make sense to consider SEEG like Marcelo did for his first case of the FCD?
Wow, thank you. Good questions. Yeah, this 3 centimeter measurement comes actually after we did evaluate all the Rolandic resections from 2 big centers. So after looking at the clinical point of view, after that, it seemed that it doesn't really make much of a difference, at least in some. So they recover. Our data are that about 80 to 90% of the patients recover after having a facial palsy, resecting this. If we only talk about the primary motor cortex, and it really doesn't, as this was the case, it was a left dominant case. So it really doesn't makes, at least what we see in our patients, much of a difference whether you resect on the dominant or non-dominant part, as long, of course, we don't, again, not going to the primary speech area, Broca and all this kind. So it's really a motor deficit that they get, but they kind of compensate it in a very well manner. What we now started doing is tracking the, like we went a little bit more further, going from another point, or at least another study about the SMA, and we kind of see if you have a very well built Aslan tract from the Broca, so about the speech, we think that if you track this, it goes also to the primary motor cortex of the face. So I don't know whether, so we kind of a hypothesis, we're now looking at the data, whether this would be like a structure you could track and see how well they will compensate and recover from the surgery after that. About the second, so I don't think that makes, at least in our hands, we do resect this, and we try to keep it just below the hand knob area, the hand area. And about the second SEEG, I agree with you. The question was, we ask ourselves what benefit we'll have upon this if we do it awake and still try to push the limits. So, and we'll consider the limits to be the functional limits. So I think if it were a benign lesion, we would expect then an SEEG would make sense. But at this case, we decided that we'll take as much as possible, and if it's possible, then the whole thing out on awake condition. So I wouldn't have gone further, even if the ECG would have showed, for instance, some well, let's say some spikes from the further motor areas just beyond the tumor. The question would be if he gets a temporal lobe seizures or something like this would be interesting. Then we'll use an ECG. So if it changed the semiology or something like that. But in that case, it would be difficult, or at least I don't know. We wouldn't change much of our resection or surgical strategy. And I don't know whether this answers your questions, but maybe this is also a good discussion for the panel. And just connecting with this question, I also have a question to Marcelo, because this was the first case. This was a really great case, and you did a very vast investigation with the SEEG. Although you have already had a target, like in the post processing, or at least. So, what's your opinion about really doing this vast SEEG with the motor, with the pole central going far away from the lesion, or just putting one or two electrodes in the lesion to show that this lesion is the epileptogenic one, maybe a third one just outside to be sure that the seizures are spreading to there? How would you could you discuss a little bit upon those things, because we have this discussion in our rounds, how many electrodes are necessary if you have a target. If you don't know where to go, then I agree. And of course the mapping, but you still, because of the location of the lesion, most probably you still do your resection quite localized, as you showed actually. So this search strategy, how important do you think it's very important to put more SEEG electrodes inside, or do you have a target, or it's enough to have the target with one or two electrodes and then you go for the resection there?
And Marcelo, before you answer, may I add a continuous question to this? Would you consider, since you have a very typical MRI finding of a cortical dysplasia 2, A or B, because this is the only diagnosis there, if you would consider going ahead without any invasive and just take the lesion out? So 2 questions, Daniel and mine.
Yeah, very good questions, actually. I think that now, as I said, in hindsight, it's easy, but initially, we actually found that radiology sets out that the scans were normal. So it is now, and we look at it, we can tell now that there was a cortical dysplasia. And this is one thing. Second thing, and this relates to Daniel's question, is that particularly the seizure semiology was not that specific of the Rolandic area. She had this bilateral twitching that's pretty much more related to the supplementary motor area. So we thought we were dealing much more with a case of frontal Rolandic epilepsy rather than a pure Rolandic one. This is why we've decided to cover a wider area than just going into the lesion. That would be an option, but we felt that the connectivity was much more widespread. And also we wanted to stimulate the motor area. So we wanted to make sure that that was the motor gyros. So that's why we put some electrodes backwards. You certainly know that in general, even though it's a type 2B cortical dysplasia is very localized, but we try to resect as many tissue as we can, even in the Rolandic area, as we did. I mean, we could be more economic in our resection, but we try to be a little bit more aggressive so that we could, expect more or better seizure outcomes. So we could, I think we could just, put an electrode into the lesion and find out that that's where the seizures were starting from. Well, I think that's important to have a full mapping, so you know where all the structures are and what the whole epileptogenic area is. That's pretty much what we do when we insert tactile electrodes. It's pretty much we try to map the whole epileptogenic network. So that's why we did it, and I think that worked out quite well. I don't know if, as I said, to go straight for the operation, now it looks exactly like a type 2 FCD. But I don't know, even if I look back, I'm not sure if I would just go and remove it without, further information from SEG.
But then let me the devil advocate and rephrase it. So suppose you do have an MRI which is clearly showing a cortical dysplasia, like it's not adult, as you know it is. So you still would prefer to go ahead with invasive, and if so, SEG or subdurals, or you would go and directly take the lesion out and see what happens?
Yeah, it depends on some factors, but yeah, I mean, if in this case the lesion was interhemispheric, it was near an allocant area, so that's why we chose to do so. But to fully answer your question, if there is a cortical dysplasia, type 2B, a very well-defined lesion on MRI, everything's concordant, semiology, neurophysiology, and so forth, and the lesion can be resected, and it's not near an eloquent area, I think I would go without any invasive monitoring. In this case, we had these red flags, the eloquence and location, the medial location, and so forth. So that's why we chose this strategy. But indeed, if the lesion is easily resectable and everything converges into a single strategy without the need for invasive monitoring, I see no problem in going straight to surgical resection. Certainly.
Yeah, not to mention that there are many when I say remove it, resect it or ablate it, because I'm pretty sure many people would lead it if possible. Christian?
Well, the last two questions were exactly the questions that I wanted to ask, but I have another one for both of you. So if you have a clear lesion on the MRI, let's say Rolandic lesion on the MRI, very clear lesion, and you're doing the SEG, what is the result? What must be the result that you abandon surgery? You know what I mean? If you have in the SEG a very widespread epileptic network, let's say, would you then say, okay, that is too much, we don't go for surgery? Or would you, so what is then the decision making around this? Because very often you have then the more electrodes you put in, the wider the epileptic network might be, right? So what is then the decision making, how to put it?
Marcel, Marcel, would you like to?
Yeah, I'd like you to answer for them, because that's a very tough question. Again, I like the differences in the children and adults. I think in children we can be a bit more aggressive. Of course, if the epileptogenic network is very, very widespread, I think the surgical decision is certainly difficult. But we did have some customized approaches for patients, so you can not only remove the lesion, particularly stay inside it and make sure that the patient is not doesn't have any deficits after the operation. And you can also, if you're sure that the epilepsy spreading goes beyond the limits of the lesion, you might go this extra mile, as I mentioned, because in children particularly, they will recover. But of course, if the network is very, very widespread, of course, it's a case-to-case decision. But I think it might render a surgical therapy impossible or not feasible.
And with us, it's we have this. I think these are two difficult, two different ways of working on this. The school of, or at least the way our epileptologists think and their thought, and when we discuss with them, they're more like very much, they do many non-invasive, and then if they kind of either by post-processing or spec PET, putting all this inside, like they try to localize one lesion, and if it's the case, as you said, it's a visual one. Our strategies most of the time is to go, and if you see it, so the resection would be, so we would like to know whether it spikes, and then you go for the resection. So most of the time we prefer, if you, I don't know if you can say the one strategy is search and destroy, and the other one is proof and destroy, so we would most probably, at least our center, we are the opinion that, or at least we go for proof and destroy. And whether when you, because now when we're talking about epilepsy as a network disease, so we always talk about the networks, but still I do think that you need a generator, a pacemaker, and most of the time it would be still the lesion, at least what our experience. So I think that that's why we would probably put an electrode somewhere or in there, one or two, and if it proves to be the generator, or at least we see a spikes and see an epileptogenic activity, there is nothing what would preclude us to perform the surgery. So we will do the surgery either way, but we need to know, especially if it's the Rolandic, that this is something causing seizure. So this has to be proved. So, but I have many times this discussion, and I know there are different type of schools. So at least the way our epileptologists they perform, they would like to have a very straightforward hypothesis about the lesion, and then only to have one or two electrodes there to prove that it is the right one generating seizures, and especially if it's eloquent, so or some to a cortex with a functional meaning, like why the Rolandic. So this maybe answers to an answer to your question.
Thanks, Daniel. Marcelo, Bertio, please.
So I'm just going to say that I'm very much advocate your suggestion to just take it out. We have gone more and more pragmatic, I think. I think that your case, Marcelo, is perfectly all right to do it with all these SCG electrodes. On the other hand, the areas are quite resectable, and probably we would have gone without ECG. And what is my favorite thing to say is that never forget your sensibility in your surgeon, in your fingers as a surgeon, because even if it is an FCDA, so you quite often you can feel the consistency change of the brain tissue. So I am more and more pragmatic, and I have operated some lesions, DNS and so on, very close, so almost inside the premotor gyrus. And if it's so close to the premotor gyrus, and if you stimulate per peroperatively, then you of course get motor response, because it's very difficult to differ a stimulation 0.1 millimeter from the posterior border if the lesion is anterior, and sort of say it's safe. So I think it's a good case, Marcelo. Probably we would have taken it without SEG. Thank you.
Yeah, thank you.
Well, I think you're kind of let's say lucky, because the patients we see with Rolandic phenomenology during their seizures, they all have normal MRIs, good, very good, high quality MRIs, and MRIs. We basically are seeing only patients with normal MRI. So suppose you do have a patient with a normal MRI, it's really normal, you have repeated, done it again, go 3 Tesla, 7 Tesla, whatever, reconstruct, whatever, but it's still normal. And have Rolandic phenomenology, let's say focal motor seizures of the arm. What is your strategy? How do you evaluate them? I guess you are going to invade them. So if you're going to invade them, are you going to be doing this with subdural electrodes or SEG? What is your, suppose a kid or an adult with focal motor seizures of the left arm, normal MRI. What is your strategy? What did you do?
Is it me, Arthur?
Excuse me?
Who are you asking to? Is it me or
Well, both you and Daniel, and that one after you answer, I would extend to the panel, because
okay.
I think.
Well, we've been using mostly SEGs, I think, as everybody. Subdural electrodes shouldn't be put aside, I think. Particularly if in the Rolandic area, in the convexity, it can still be quite useful. But for normal MRI, I think, because we wanted, even if everything converges into the Rolandic area, I think that we still want to make sure what the boundaries are. So I would put a lot of electrodes where I think the possible epileptogenic area would be. And then, when I have the results and can establish all the connectivity within these areas, then I would probably come with a strategy. And I just want to say, because I completely agree with what Bertil said, because this lesion was indeed mostly into the SMA. So that's why I would get it. And we're going to get response indeed. And I think we could go without exploring, without an SEG. But, in this case in particular, that's why I wanted to show it. We had the suspicion prior to the operation, and SEG was actually much more, confirmed all our suspicions. So it was certainly very helpful. You might, not use it, but when you use it, it can be quite helpful. So I think both strategies are acceptable. It's just a matter of whether you're absolutely confident or not. Maybe it's because I'm still young and I wanted to have more certainty of what I'm doing. But I want to gather as much information as I can.
Okay.
Thank you. Marcelo?
Well, Ada, to answer your question, and maybe being like devil's advocate, I would say that we would most probably do a little bit more diagnostic, like a high density EEG and 1010 electrodes. And if we cannot get a source localization, something to put an electrode in, I presume that it will go for a neuromodulation without any further invasive diagnostic. So if it's a completely normal EEG, 7 Tesla, 9.4 Tesla, so you don't have a SPECT, you don't have PET, you have nothing, then you have a high density EEG, also nothing, no source localization. So it's the Rolandic area. I would say most probably we wouldn't go even for an invasive, because it will be how would you like to, how many electrodes would you like to put in, where would you like to put them, and after that, how you want to tailor your resection according to this phenomena. So most probably we would go directly to a kind of a neuromodulation.
Guy, you're too quiet today.
No, I'm just listening.
I hope listening and enjoying.
It's a good conversation.
Yeah. So how would you manage them, Guy?
I think we would still, if we suspected Rolandic, it was truly MRI negative, everything negative, I think we would implant and explore the area. You know, I think one of the comments that are out there.
Explore how? Subdurals or SEG?
No, we would use that. I mean, we would have previously done subdurals, but now we would do SEEG. I think also in the region, it's very hard because sometimes seizures can spread very, very fast. You can think maybe they're Rolandic, but in fact, they're coming from anterior parietal, or they're coming from SMA or pre-SMA. And so I think having the question before about, particularly if you're not certain about a lesion, or if there's no lesion, being absolutely certain about where you think the seizures are coming from spreading, and particularly how quickly they spread. And also, a couple of the comments mentioned the importance of being able to stimulate through the SEEG electrodes and recapitulate the electrographic and clinical pattern of seizures. I think that stimulation is a very important part of the SEEG that has to be taken into consideration in these peri-Rolandic epilepsies. So we would implant with SEEG, and we would record, and we would add more electrodes if we don't think we have everything covered. And then we would make sure that we'd spend a lot of time stimulating.
Jeffrey, would you join the conversation here and show
Yes.
yourself? Do not hide. Show yourself. Okay,
Do not
good.
Great conversation, and I think it raises several interesting points. At our center, I think we would imitate a lot of what Guy said, that we would use SEEG initially. We almost think of it as a step less invasive. So I think it would definitely be, we would not want to miss a deeper focus. So we'd investigate with SEEG. But if we were convinced that it was a superficial peri-Rolandic or peri-Rolandic, we might even follow it up with a grid, simply because in children, it just gives the best localization for surface topography as far as exactly where motor cortex is, but just a short duration that would not be the primary objective. But the main point I wanted to raise was really in response, and it captures your question and also Christian's issue. And it's that issue of I think we're at a point where there's tremendous variance in the availability of neuromodulation strategies. Because even if you live in a privileged or an affluent country, there's a lot of variance from place to place, center to center, even financial insurance situation, one to another. Guy is as progressive a place as exists on the planet with regard to use of neuromodulation. And for kids approaching that 15, 17, 18 years, where in the US you have FDA approval for some of the neuromodulation strategies, it opens doors that we don't have even in kids that are 8, 10, and 12 for these neuromodulation strategies. So I think just kind of reflecting, neuromodulation is an area where we have tremendous variance, both across the globe and even within this interesting conversation.
Thank you, Jeff. Christian, please. Not to mention that there's so far not a very good option for neuromodulation in the Rolandic area, except maybe trying RNS over it, but the results are not so great.
Absolutely, and particularly for what you mentioned, which is focal motor, right? That's really difficult, right? We would aggressively try and pursue resective strategies up to the point where Christian said, what if it's a wide network? Then that might be a little different.
Christian, please.
Yeah, so I think for this MRI negative Rolandic epilepsy, we would have the same approach as Jeffrey just mentioned. The level of confidence in this Rolandic epilepsy that you can say, okay, this is truly coming from the Rolandic area, is very rarely the case. So what we would have done is put in SEG, and if then Rolandic area is confirmed, I think this is the perfect place for subdurals. So we did subdurals in the past and are using SEG in most of the cases now, but I think this is the perfect indication where subdurals still have would be a good option.
Yeah, indeed. It's clear that we are going to be using more and more SCG, but it's also clear that some patients benefit from subduros, and the issue is that some of the manufacturers are stopping to produce the subduros. So if it goes like this in the near future, you're only going to have the option of SCG because you're not going to have any. There are still some manufacturers producing them, which is great, but some of them are just giving up for producing subduros, which I don't think leaves us with options, which might be needed at some point. Daniel, please.
I have one question for the panel, because talking about the neuromodulation, there is this device now on the market, this EASY or EASE device. So it's a extracranial subcutaneous stimulation. Does someone has an experience with this? And because this would be exactly what it is meant or was produced to stimulate, especially in eloquent areas, if you have a spread or wide network and don't have any lesion. But my question is whether someone of you guys has any experience with this. Does it work, or what do you think about it? Or would it be in a case of a non-lesional epilepsy, would you use such thing? And Rolandic, of course.
Does anyone have any personal experience with EASE?
Yeah, so you were talking about the device published recently in JAMA by Schulze-Bonhage, right? Yeah.
Yes, that's correct.
So we did just one case couple of weeks ago, and the procedures itself is very convenient, but unfortunately, I don't have any seizure outcome data for this because it was just a few weeks ago. But yeah, maybe in these MRI negative cases, maybe an option in the future, because the result is actually quite the same as for VNS and DBS and RNS. It's 50% reduction. Whatever we are doing, we are getting a 50% reduction, right?
Yes.
Yeah, I don't have any experience with it either. I will second what Arthur said. In the limited number of cases where we've tried RNS in the Rolandic area, we have not had very good success. I think that the other issue here, unlike the situation where both of you are describing, where, when you have a lesional epilepsy, and particularly if it's a more benign lesion and you're willing to take more risk in terms of potentially giving somebody a deficit, whether it's a mostly recoverable or fully recoverable deficit. When we get to MRI negative, right, it's a much different story, because our chance of being successful is a lot lower and our chance of giving a significant deficit goes up. And so I think we just have to be very, very cautious about, not creating double losers where we give somebody a new deficit without solving the epilepsy. And so whatever technique in our own centers works best for us to define, I think we really, really have to know exactly what we're going after in these MRI negative cases, because those are some of, I think some of the highest risk cases we deal with.
That's true. They are Rolandic, but they can come from the frontal or the occipital. I brought Erasmo to the panel. Erasmo, are you there? Not sure.
Yeah, I'm here. Sorry.
Okay, good.
How you doing?
Great. Can you appear in the camera, or you're trying to hide for some specific reason?
No, I'm good. I'm wearing my workout clothes, but I hope you guys don't mind. How you doing?
Okay, so go ahead. You have some comments. Maybe you could voice them.
Yeah. So as you all know, really, whether it be lesional or non-lesional, or let's say MRI negative, MRI positive, it all goes back to the work that the epileptologist does beforehand to localize, because as you know, the electrodes provide limited sampling unless you have a good hypothesis. And then, so, particularly with motor cortex or paravolandic epilepsies, as Guy was mentioning, that area is so tightly connected to SMA, pre-SMA, cingulate motor, that if the electrodes are not in the right spot, even when the electrodes are in the right spot, you see propagation, very early propagation, that if the electrode was not in the right spot, one would think it's a broad network, because that network gets very widely distributed. And also, sometimes the epileptologist fails to recognize that there's a homunculus within the ventral motor cingulate, so that you can get focal motor signs within the ventral motor cingulate, and that area propagates to the precentral gyrus, making one falsely believe that that's where it begins. The other important point is, from an epileptologist point of view, is that, video monitoring has to be very meticulous and going over the semiology like hundreds of times with the patient and the family, because they don't know what's important, but those early semiologic signs will point you in the right direction. So oftentimes medications are tapered quickly. Well, the problem is with these perirolandic epilepsies, the seizures spread very rapidly. One needs to see the early components, because those early components will point you in the right direction. And we've had 2 recent cases at Johns Hopkins or Children's where those early semiologic features helped us. So one, the family described facial motor clonic twitching as the first symptom. But really what actually occurred is that the patient had a sensation of movement in her eyes that preceded that by 15 seconds. And sure enough, we end up finding a dysplasia within the precentral sulcus. And then another patient with seemingly 3 different semiologies, but depending on how the seizure propagated, and there's another lesion in the precentral sulcus, that she would have either head movement downward or left version, depending, and we could stimulate each of those seizures. So if those electrodes are in the right spot, you can break down the different components of the seizures, which increase the chance of seeing or mapping the epileptogenic zone, and sometimes in retrospect, going back to the MRI to hopefully find it. One last thing is that I think is essential is, as you all know, a lot of centers are not doing 3D volume flares. A 3D volume flare is essential in conjunction with the T1 MPRH, and then co-registering that to the PET, because focal dysplasias type 2 and type 2A and B will show focal hypometabolism. And if you see that with what you think is something, then that's probably a focal cortical dysplasia. And then the last part is that sometimes type 1 dysplasias, which are very, very elusive, is that the sulcal anatomy is different. So understanding the sulcal anatomy is important, because sometimes, granted, there are variations in the sulcal anatomy, but sometimes some of these patients with type 1 dysplasias have a sulcal anatomy that is very aberrant. It's not a polymicrogyre, it's just the sulcal anatomy. It's just not normal. And you have a greater degree of confidence when the semiology EEG is fitting that region. And that also helps to plan the SEG.
Thank you so much for joining the conversation, Razu. Truly appreciate it. We
My
are
pleasure.
running out of time. Marcelo and Daniel, would you please give your final comments before we finish?
I just want to thank Arthur and everybody else. It's been a great learning opportunity for me, as I said. It's nice to be amongst these great figures of epilepsy surgery. I think it's a very challenging topic. I'm still delving into it. I don't think I have many of the answers I'd like to have. So it was a great pleasure to be here, and thank you very much.
Thank you, Marcelo. Daniel, go ahead.
Well, for myself, thank you for the invitation. I think it was a great discussion. We touched upon almost every important aspect of diagnostic issues and resective issues and neuromodulation issues concerning the Rolandic epilepsy. I would say that I think it's, as a final remark, maybe, I think that we are heading up a new era of neuromodulation devices. Actually, there's a very nice paper from last year from the US American centers. You evaluated all this. You have like a 140% increase of neuromodulation techniques, and all resective surgeries are decreasing. So I think this is a sign that something is going on in there. And I think something what we also discussed today is that we have to look on the molecular pathology. And as it was in your case, Marcelo, maybe if you would look for a BRAF mutation, this pleomorphic xanthostetoma, then you have also another target for a targeted treatment. But these are all aspects that are getting us concerned, and we should get involved in all this developments. And it was great pleasure being here. And Thank you so much.
Thank you so much, Daniel, Marcelo, again. We are finishing this session. Please stay tuned for our next webinar in 2 months. I'll be opening the post-webinar room for the panelists. Thank you so much.
Thank you. Bye-bye.
Thank you. Thank you.